Hey, you guys, welcome back. So today we are going to more or less continue on the conversation from last week. And if you remember it all, I mentioned there was going to be some redundancy. So I was looking through the slides here that I have behind me, and there are some things that are probably going to be, I'm going to skip over them because I talk about them in both places. And so eventually I'll update this and make it better so that I don't do that. But for now, you'll see me skip over some things. As a reminder, too, these are, when we talk about these sort of foundational principles, in some ways these things are so intuitive and probably seemingly obvious to a lot of you, but they're so important because later on you're going to come back to this stuff and say, oh, this is why I'm doing it the way that I'm doing it, or these are the choices that I have to make. So it is kind of, even though it seems sort of like basic and almost like elementary in terms of like psychology 101 that you took in your undergrad, this stuff becomes more nuanced and complicated as you get out into the field, and you may not recognize that until later. So I'll kind of jump in here and explain what I mean by that. So first of all, just as a review, we talked last week about the three broad categories of assessment, from interviewing to testing to observations, and we'll dig a little bit more into those. And I'll try and add sort of supplementary information and not be just repetitive, but that's kind of what we covered and what we're also going to cover a little bit today. And then interviewing. I mentioned here that this is often where counselors stop. And the reason I say that is because assessment in terms of like formal standardized stuff sometimes gets used, but primarily when counselors are sitting with another person, the philosophical foundations of clinical counseling work is you have this unique person with a unique situation. In order to find out what that information is about their uniqueness and whatever sort of symptoms they have and how that presents in them, that just requires asking questions and finding out from them. There are tools that can capture that, but there's a whole bunch of nuance too. So interviewing is important. And many of us, if not most of us, want to spend our time talking to the person and really getting to know them and providing therapeutic benefit. And sometimes assessment can, it doesn't necessarily have to, and it maybe shouldn't, but it can have the feel of it's just gathering information that feels like it's for me and it's not providing benefit to the client. However, if done right, it can have therapeutic benefit for them as well. But that's just, we'll talk about that more later. And then, of course, there's informal and formal tests. So we'll dig into those a little bit later, too. Please move forward. There we go. Okay, so in terms of interviews, we did talk about some of this last week. Interviews provide context. They give that nuance. So there's not a whole lot I want to say more about that. Probably that's a little bit intuitive to most of you. In other words, you want to gather information, the sort of stuff that you can get on a clipboard. I want to know your history. I want to know your name. I need addresses. But I also need to know how it feels to be sad, or how what your relationship is like with your spouse, or whatever those things are that you just can't quite get on a piece of paper. How you decide whether a test is appropriate or which ones you need is part of the interview. In other words, someone will come in, maybe you do some screening assessment at the beginning for certain conditions that are very common, depression, anxiety, whatever, just like the stuff you've done in your doctor's offices. You get that information about family background, about basic symptomology, and then when they come in, you might say, okay, I can get some information based on my questions and my unstructured interview style, but I also maybe don't have access to other kinds of stuff because maybe, for example, you don't know how to talk about your feelings. And so we need this tool to then bring in feeling word options for them to write down on a piece of paper. Or maybe we're talking about your personal values and somebody's like, I don't really know what you mean by that question, and say, okay, we'll have a test here that can help us discover a little bit more about what your values are. So in some ways, testing can happen up front. In some ways, you talk to a person and then you find out, oh, we probably need this other test. This is not unlike going to the doctor's office where you say, I'm going to make an appointment because my throat hurts. And they're like, okay, well, there's a million reasons why your throat can hurt. So why don't you come in, tell the doctor, and the doctor will determine if any more testing is needed for strep or for throat cancer or whatever the thing might be. So if you think about your visits to the medical doctor, it's similar in the sense that we use our clinical judgment to say, oh, we need more information of this kind, and I know how to get it. That's sort of what this process, what the interview can lend to us. And then, of course, for number 3 here, you may have more information in advance, and we can weave that in a test. I think that means into a test. I keep finding things on these PowerPoints where I'm like, that I don't know if that's English, or I'm reading it as I'm talking here in my office to myself, and I'm like, I'm not reading it right. So I think that's English, but you guys be the judge. So we gather information from these different places. This is the whole idea. And then you put it all together to make this cohesive understanding of a client's presentation or your understanding of them or whatever. Structured interviews, we will talk about those, but very briefly. They're not a huge part of the counseling world. However, it's important to understand them and know how they work and why they're working, because I think the way that I hear other people talk about these kinds of things is that those things just, like, they're important and yeah, they have their place, but it's not for us. It's not something we do because we need the flexibility to go into an interview with a client and just sort of let it go where it goes and let the client kind of lead, especially when you're thinking about, like, what are the goals? What do you want to accomplish in counseling? That kind of stuff. And we tend to want to let the clients lead those discussions. So it's just, there's this tone of like, we don't want to structure it for them because we want them to tell us what they want to get out of our counseling work together, something like that. However, there are really great benefits, especially when you're thinking about scaling up how you're gathering information. And just, this is a touchy subject, but when it comes to understanding, making like political choices, or if you're advocating on behalf of an entire community of people, if you're like, I want to support whatever, like men's, what is it, like, I don't know, gun rights. Mental illness comes up whenever there's conversations about gun rights, or I want to support the LGBTQ plus community, and you want to gather a bunch of information. It really takes gathering, having some structure to how you're asking those questions in order to gather that quantity of information. So just like another example would be like educational testing. If the federal government wants information on how students are learning and what they know and what they don't, they need to send out the same test to lots of different kids, right? Like all the way across the country. And in that case, you want to make sure that you're testing Georgia the same way you're testing Oregon. So having a structure to that assessment is really valuable and important, more so when you're doing it with groups and less so when you're doing it with individuals. So that can be an important distinction to understand why structure is important. But then again, if you're doing clinical work with just one individual, it may be less so, but it's still important to understand how it works and why it works. Because when you say, well, the data on bipolar 2 says this, and by the way, the data means hopefully as much as we can possibly gather over time, over space, that kind of thing. And when the client says, well, how do we know how that fits with me? You can say, oh, because data is important and it tells us this about this many people over this time span, whatever. So anyway, enough about that. Semi-structured, I think we covered that last week. We can kind of move over that. And then we talked about an unstructured interview not being an agendaless process. That's the words from the textbook. And just to reiterate, because I think this is so important, it doesn't mean that you're just sort of like going into your counseling session saying like, well, I don't know what I'm doing. We'll see what comes up and let the client say whatever the heck they want. We have a responsibility to come in with some experience and something to offer. And part of what we can offer is we can say, I can help guide this experience for a client in a certain direction. And what I mean by that is if just to use an example, let's say I'm a cognitive behavioral therapist. And because I'm a cognitive behavioral therapist, I'll just chop that in half and just take the cognitive portion for now. Let's say I know something about where people's cognition goes awry. For example, Aaron Beck was really famous for coming up with all these cognitive distortions, things in our mind that we get wrong. Just use one. So magical thinking. Somebody comes in and says, my husband is so annoying because he's always thinking about blah, 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 whatever. So that's one of those sort of fallacies in our heads of like, I think I know what is going on or what's going to happen or how he's perceiving or something like that. And when we hear that as counselors, we say, oh, that's one of those distortions. Client doesn't know that. I know that. And so we can say, well, tell me more about what you know about his thoughts that are going on in his head that you have never actually heard with your ears. Has he told you these things? Or this is part of your discussion, or are you sort of assuming that you know? And that way we can kind of lead the conversation based on our theoretical perspective of what we know works and what doesn't in the human mind. So it's not like we don't have an agenda. I want to help the client come to a better place, have better relationships, have a more satisfying and meaningful life. But I get to make some clinical choices to help guide that process. So when we say, tell me about your husband, and client responds that way, we can say, oh, based on my training and education and experience, I can kind of guide the conversation in different directions to help them get to the place where the horse can be led to water and they can choose to drink if they want to use a timeless metaphor. So anyway, that's what that one means. When I say down here, know your theories because they guide your questioning, that's exactly what I'm talking about. Just to give another example from a completely different theoretical perspective, this is a wildly different one, and I think these ones are fun. So I'll give one more example here. Let's say I have a feminist perspective, and I don't teach the theories class for you guys. I have in the past, but I don't do it now. But I love talking about feminist counseling because it's not just about women's rights and shaving our heads and burning our bras and that kind of thing. That is part of it. But another part of that, which from my perspective in rehabilitation counseling that's really important, is looking at people through this hierarchical social arrangement that we have. What I mean by that is that for people with disabilities, when they come in and they say, I'm having a hard time with something, one of the things that we can usually assume because of several different reasons, well, I guess I'll explain this a little bit because I think it's important and valuable in terms of assessment. So if you've heard before us talk about, some of this will be new to you, some of you have heard it before, the medical model versus the social model. The medical model says that for hundreds of years, we've been looking at people, and if we can go in as a doctor or physician or whatever, and I know that there's a virus in there, there's something inside that person that's not working, not functioning, it's wrong, it doesn't belong in the person's biology. If we can take a medicine or surgery or some sort of medical intervention and go in there and take out the problem and return them to whole functioning life, they'll get better. The social model says, well, but in counseling and in disability and in this world that we live in, sometimes it's not me that's the problem. It's not a problem within me. It's a problem in the way the world works. So here's an example. A person with a wheelchair is rolling down the street and they want to get up onto a sidewalk, but if there are curbs everywhere around that sidewalk, they can't use the sidewalk. So they go into the street, and let's say they get honked at by cars and the police come and say, you can't be in the street with that thing. And they say, I'm not doing anything wrong. I don't have access to the sidewalk. The problem is not me. It's whoever built the sidewalk. The city is not making it accessible for all people, not just people with wheelchairs, but bikers and pregnant ladies who don't want to step up curbs and whatever it is, old ladies with walkers, whatever the thing is. So the social model says there's a problem outside of me, even though I'm appearing to do something wrong. So that's what the social model is. The way that relates to feminist work is I can say, well, let's look at who has the power to make those decisions. Is it that person in the wheelchair? Or is this person subject to an environment that does not allow them to function or thrive? Now, step outside of that example a little bit. Let's say you're working with a kid, or could be so many situations here, but let's say you're working with a kid and the parents bring him in and say, my kid is just a problem. I don't know what's going on with them, blah, 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 blah. Please fix them. And you're like, okay, tell me about your parenting style. What's it like at home? Tell me about how you respond to the kid when he's acting up, something like that. And you may come to find that maybe the kid is not the problem primarily, but it's the environment they're living in. Now, there's a power hierarchy there. And this is where it gets interesting. Feminist theorists or feminist counselors look at those power hierarchies. So when I said it's sometimes about women's rights, yeah, that's true. But sometimes just looking at the power hierarchy of like, what's the environment like and what things are outside of that child's control or that person with the wheelchair outside of their control, they can't change the curb in an instant. It would take a long time of voting and advocating and all that kind of stuff, some of which may not be within their control to make that choice. So it's kind of like civil disobedience at that point. You can't ride your chair in the street, but you can't make the changes to do the thing you're supposed to do, so you're kind of screwed either way. And you could see how a person could struggle with that. And in this context, then, we can use that theory to help guide our questioning. Is this a problem with you, or is this the problem with your environment that you have no control over that we got to find a way to cope with because it sucks and it's not your fault? So hopefully that long winding path leads back to an understanding that when we're doing an assessment of a person, part of what we're thinking about then is are they the problem, or are they subject to an environment that does not allow them to thrive to their fullest potential? Something like that. Two different examples: cognitive behavioral, feminist theory. Your theory will then guide how you understand what the problem is. Is it up here or is it out there? Something like that. It's just a basic way of understanding it. So when you see another extension of that is when you see other people's assessments, if you don't understand what the theoretical foundation is to how they got to their assessment, or by extension, if you're not sharing with people how you got to your conclusions. I'm a feminist theorist. I understand power hierarchies to be important, and therefore I think this client is not suffering from mental illness. They're suffering from a society that sucks, or something like that. You wouldn't write that necessarily in a professional context, but hopefully you get the point here, is you have to let people know how you came to your conclusions and what your conclusions mean for that individual. So there's a lot to unpack there. That was a lot of stuff all at once, but hopefully that makes a little bit of sense. Okay. This is one where we're going to spend a little bit of time on. All of these are kind of just like random points pulled out from the textbook, but they're kind of important in understanding how do I choose tests, what do I use them for, how do I understand them, that kind of stuff. So let's take the first one, and I'll try and go through these kind of quick and not be redundant, but some of them are important I want to spend a little time on. The difference between high-stakes testing and low-stakes testing will determine a lot about how you approach them and what ones you choose. So let's take an example here. Let's say someone comes in for a career evaluation, and you're working in a school setting, let's say, and they're like, well, I'm in special education, and I have to go to this alternative school because of behavioral issues or whatever. And you come to find out that this kid has a pretty rough home life, but if they could learn a few things about what their career potentials are and learn about themselves and who they want to be, maybe you decide that career evaluation is important. So the context really doesn't matter, but let's say we're doing a career evaluation and that kid does the career evaluation and doesn't have a lot of insight because of living in this stressful, traumatic situation for most of his life. He doesn't really know, like, what do I like to do? I don't know. I'm just trying to survive every day. So he takes a test, and the test says, you are says you really appreciate sciences and you're interested in science and you show great intellectual potential through an aptitude test. We haven't talked about aptitude tests, but aptitudes are things that you have potential to be good at in the future, even if you're not educated to that level now. You have potential to be good at later. So they show high potential for science-like stuff. And you say, well, maybe you should think about going to school to be a dentist or whatever. Well, you wouldn't say that to a kid in junior high, but let's just, for sake of example. And then that kid goes through school and finishes and graduates and says, someone told me I should be a dentist, but I actually only have the availability to do mechanical stuff, like be an auto mechanic or whatever. And they become an auto mechanic and they're good at it and they're successful and all that kind of stuff. Does that mean that your testing was wrong and it really steered them in the wrong direction and it changed their whole life trajectory? Well, maybe not. There's a lot of room for error in things like this where you could say, based on the information we have now, this seems like an option for you. But hey, let's take all these other circumstances into account too, and things can change over time. That's one of those low stakes kind of examples where if you get it wrong, it doesn't really matter that much. Let's say here's another example. Someone comes into your office and you're like, oh, how much are you sleeping in any given day? And they're like, 8 hours. And then you go through your session. Next time they come in, they're like, oh, well, I didn't really know you last time, but now I feel a little more comfortable. And I'm actually sleeping 12 hours a day. And you're like, oh, okay, that changes things. Does it change things a lot? Does it make a huge difference in the way you're doing counseling or the way you're approaching their situation? Probably not. So low stakes, right? So makes sense? Hopefully it does. Then there are situations where you might have a client come and say, I got another DUI. That's my third one, and I'm court ordered to come to this. And I had my kids in my car, so my kids have been taken away from me, and I need to go through this counseling process because I want to show the courts that I'm not a bad parent, and I'm making choices to rehabilitate myself or recover from my addictions or whatever the thing is. Those are kind of high stakes sorts of situations where your evaluation of them and the way that you assess their readiness for parenting, for recovery, for whatever that is, that determines a lot about a person's future career and their ability to have their kids around. And like, there's a lot going on there. It's kind of high pressure. And not to be overly dramatic, but sometimes, like in the Hollywood examples, somebody's commits a crime and they say, I'm not sane enough to make choices for myself to stand trial. And so people use some of the assessments that we're going to talk about. One of the popular ones is the MMPI, or the Minnesota Multifaceted Personality Inventory. It's designed to find pathology based on DSM diagnoses. So those tools are used to determine sanity, which in some states could relate to something like the death penalty. So in some cases, these things are high stakes, really life or death. In other cases, not so much. And your ability to understand a person's risk and the potential consequences is kind of important in these situations. I shouldn't say kind of. It is important in these situations. So something to be aware of. What tests you choose and how you use them may be dependent on how critical it is for you to evaluate it correctly. So that'll become something that you'll increase in understanding over your time throughout your training and beyond as you get out into the field. You'll learn about which ones are more high stakes and which ones aren't. So probably enough said about that for now. We've talked, I think, about standardized versus non-standardized enough to understand there's a difference, in making choices is important. We're not going to be able to explain to you, like, this is the situation, you use the standardized versus the non-standardized. That's something that you'll get after you get out of school and you start to see clients and you start to really you're building that, like, kind of, I use the term muscle memory, or sort of intuition, or you're training your conscience to be aware of what's, morally appropriate in these situations versus like clinically appropriate, all that kind of stuff. You'll get that stuff later. So that's why I'm covering it a bunch now. Even though it might seem elementary and redundant, it's going to matter so much more later. So we'll go into that later. We've talked a little bit about individual and group already, so I'm going to skip over that one for now. The maximum performance versus typical performance. This one feels a little bit like it was tossed into the book in sort of a weird spot. I don't have like great examples, but I'll give you a metaphor to help understand what this means. So if I'm, let's say I'm a weightlifter and I want to know how much I can lift, one way of figuring that out is putting as much weight as possible and seeing how much I can get off the floor. Like I'm a power lifter and I'm just like lifting it up to my legs or something, what's that called? A deadlift, I think. So in one case, how much I can lift one time demonstrates my maximum performance, the maximum amount of weight I can lift. But is that really a realistic measure of how much I can lift over time? Like, if I'm looking at a person and saying, like, how much can you lift? If I can do 8 reps of that same weight, that's a different thing, right? Or like, if I'm a football player, I'm like, I want to know my strength, how I can perform over the course of several hours of gameplay, not just one time. That would be my typical performance. Here's a real life example. If someone comes in and they say, I have carpal tunnel and I get this tingling in my hands and I have to stop using my hands for a while, and I'll say, okay, but you're an auto mechanic and we need to know if you can actually continue in this work or if you can't, if your medical condition is keeping you from being able to do this. One option is I could say, well, let's test your maximum performance. Can you screw on this bolt on this little sample assessment? And they do, and I'm like, oh, good, okay, you can do auto mechanic work. But an auto mechanic doesn't screw in 1 bolt per day. They do that over and over and over again many times, and they use their hands in all kinds of unique ways. So it would be maybe a better assessment to say, let's spend a couple hours using your hand and figuring out how long you can use it for. Because if you can only use it for an hour before you have to take a break for 3 hours, that really impacts your ability to be successful in that kind of work. So there's all kinds of examples of that. I'm trying to think of how that in the rehab world, and when you're thinking about working, that one seems to make more sense in my head anyway, of like distinguishing between these two. But in terms of like clinical mental health work, I'm trying to understand like how would this point be really important for us. And I'm sure it's there, but somebody smarter than me can explain it in a way that matters, because I just don't got it, I guess. Verbal versus nonverbal. So there are, let's see, how do I explain this one? I don't remember how they used it in the book, but there's kind of two contexts for how I think about this one. One of them is in the disability-related context. Some people have the ability to speak and some people don't. And let's just use an example. So let's say somebody is on the autism spectrum, and so they live with ASD, and they're nonverbal, but we're doing an intelligence test to see how much they can understand and how much, like, if they can contribute to an employment setting or something like that. I might do an intelligence test, but an intelligence test requires you to read and verbally respond. But if they're not responding, I might make the assumption, and by the way, hint, hint, we've made this assumption wrongly many times in the past, but I might make the assumption because they can't speak, they're not intelligent, which is not true, it's not right, but we need a different kind of test that'll help them respond in a different way. So, for example, if I need to use a touchpad that has responses on it, and they can use that to push a button and make a response, I can then learn something about what's going on in their head that their mouth won't give me. But that doesn't, that gives a different understanding of intelligence, verbal versus nonverbal, right? So hopefully that makes sense. There's another way to think about this in terms of like delivering an assessment. Sometimes you might give an accommodation and verbally read out the test to somebody, and sometimes you might just expect them to read it. And so there are all kinds of situations where these kinds of things matter, but we won't dig into that too much. We'll talk about accommodations later on too, especially when we talk about diversity and multiculturalism and test appropriateness and that kind of stuff. I think we've talked about objective versus subjective. Most people understand that one pretty well, so I'm going to skip over that one for now, and we're going to come back to that when we come to the chapter later in the semester about personality tests and subjective understandings of, like, sometimes you'll hear people say, like, well, this is my truth and this is my understanding, this is the way I perceive it. And sometimes it can be really important to understand a person's subjective experience of it, but then there's other measures that are completely objective, and there is a standard for right and wrong. So if you're like, what is 2 + 2? And you're like, 5. That's what I think it is. That's my reality. This is my truth. You can't tell me I'm wrong. And you're like, yeah, I can. Stop being silly about it. You know what I mean? Like, there is an objective in some cases, and then in some cases, a person's subjective experience really matters. And so differentiating those two can be a challenging thing. But that's a whole bigger topic that we're not going to go into. We'll just leave it at this for now. We can discuss it a little more if we need to. A little bit about terminology. So there are a lot of different terms. When it comes to assessment, for those that invest their lives and really get into assessment work, there's like this whole different language that comes along with it, and all kinds of different words that really make a meaningful difference. For most of us, we may not want to invest that much time and energy into that, to the assessment world. And so in some cases, I'm going to use terms like inventories, questionnaires, surveys, checklists, schedules, all this kind of stuff. There's lots of different terms for different unique sorts of assessment things. Sometimes I'm going to use things almost interchangeably. Last unit, I talked about the difference between testing and assessment. And sometimes there are nuances with words like this that really matter, and sometimes I use them interchangeably, inaccurately and incorrectly, but it's because in the way that I'm using it, sometimes I believe anyway that the differences don't really matter enough to distinguish. So this is going to be one of those tenuous things where I hope not to be too terribly confusing, but I want to introduce this assessment stuff in a way that you can learn from, that you can use, that's practical for you, that might be slightly inaccurate, but hopefully it won't misguide you in the future. This is especially important when we get to statistics, and statistics is a whole different language. It's like this mash between math and social sciences, the way we're using it anyway. And there's just like it's like a whole thing in and of itself. And so you can get really good at it. And I try to use language that helps us access it from a non-native math person perspective, that kind of thing. So a lot of different terms. I'm not going to dig into all of these individually and say exactly what they are, but just so you're aware that here are some of them, and you'll see a lot more as we go through this. The only thing I'll add to that is that even though it feels like a different language and it can be overwhelming and confusing, and when we get overwhelmed and confused, it's not a place that we like to be in. And what we tend to want to do is when we get overwhelmed and confused, it triggers our fight or flight response, and we want to say, fight, this is stupid. I don't think this is useful. I'm not going to do this anymore. Or we flight. I'm just going to not care and hope I'm okay. I'm just going to like forget about it and just like do something else and hope it doesn't matter. I really strongly encourage you to fight those impulses to either fight or flight away from this stuff. You may not know it. It might be confusing, but the more you can sit in the discomfort of saying, I don't know this right now, but I'm okay with that. I can learn if I need to, and I'll just have to do that later if now is not the time for me. Or it's confusing. I'm going to do, to use a phrase, I'm going to trust the process that later on I'll understand it, but for now I just don't, and that's okay. That's an okay place to be. So lots to learn, lots to understand. Not all of it you have to, and that's an okay place to be. So that's kind of, as it relates to testing language and as it relates to statistics and lots of parts of counseling, it's okay to not have it all figured out now. You will get there, hopefully, but it's okay to be uncomfortable about feeling inadequate at this moment. And the more you can sit in that place of discomfort, the less you'll need to compensate or use defense mechanisms or cope in unhealthy ways, that kind of stuff. You can just say, I'm okay being imperfect right now. I don't know what these mean. I don't know the differences. And that's just an okay place to be. Okay, so enough of my lecturing in that way, I guess. I have to keep lecturing a little bit, but hopefully you get the point. Setting matters for testing a whole bunch. What do I want to say about that? I don't know. There's just, if you're doing group testing or individual testing, if you're screening somebody and you have them fill this out in your waiting room and all these chairs are crammed together and there's a potential they're not going to give you accurate information when they're sitting next to some stranger and they're filling out something about their symptomology or potentially embarrassing things, you may not get good results. And so considering where people are testing and how they're testing and whether it's conducive to getting the kind of information, that's a validity concern, which we'll talk about what validity is later too. So I'll just leave it at that for now, that setting does matter and it does affect the quality of information that you're getting and accuracy of it too sometimes. And then the last part on this slide is paper and pencil versus computer. I don't think there's a whole ton that I want to say about this right now, except for there used to be this reluctance to virtualize things or to put them in electronic format. And one of the interesting things that happened during the COVID-19 pandemic in like 2020 time was like, people are like, no, people have to be in person. They have to come in. You have to test in person. And sometimes that is the case. And sometimes you cannot get information or you can't get good results unless you're with a person observing, that kind of stuff. But in other cases, people didn't believe that testing could be done on a computer. And then COVID-19 happened and everybody was stuck in their homes and they were like, oh my gosh, we need to figure this out. And they did. and things were moved over to computerized versions. And in some ways, we've gone back to the old way. In some ways, we're still using the computerized version. So some things you'll find on computers, and there's still value in using paper and pencil in some ways. So it's a test by test, person by person kind of situation. So I'm not going to dig into that one too much. But in terms of how you administer and how you're using results and who does the scoring, some things computers do really well. Computers do math way better than all of us. I guarantee it. 100% I'll stand behind that comment that even though I might be confident in my math abilities, human error is not as accurate as computerized mathematical computation. However, a computer cannot see nuances and it cannot understand sarcasm and it can't understand humor and those kind of things. Even with advances in AI and large language models like ChatGPT and all that stuff, it's all the rave right now. 2023, it's like the big thing in the news. even with all that stuff, it's not there yet. And there's still things that have to be done paper, pencil, or in person, or from a human. And so that's a whole conversation that's going to affect the way we do counseling in the future and the way we're doing it now even too. So pretty interesting stuff in my opinion, but more than we're going to go into in this class. It's kind of outside the scope of probably the class, but at least today in this lecture. So, okay. Observation is one of those things we look at and we're like, yeah, it's just like looking at people, right? What's the big deal? I get how to do that. I have a pair of eyes, or I can hear, or I can, I can sense something, and that's part of that observation. However, it's deceitfully simple. There's so much more going on in observation. Here's an example. It's one thing to say, I can observe behaviors, because if you're a behavioral therapist, you can watch somebody and say, you picked your nose 5 times, and I'm here to help you not pick your nose anymore, to do some behavioral modification. So maybe you didn't recognize how many you were, and if you had how many times you picked it, and so now that you have that insight, you might say, oh, that was more than I thought. And so then you work through like, well, how do we then recognize and become more aware of what behaviors we have, and whatever. Silly example, but you get the point. Another part of observation, though, is how astute am I at understanding when a person needs me to be supportive or empathetic? So just a sort of a wild example. We live here in Montana, and Montana has a lot of really like stoic men who don't show emotion in their faces or something. However, we know that people have all kinds of thoughts and feelings going on behind their stoic exterior, but we may not be able to see it. So it does take a special astuteness to be able to observe. A person is saying these things with their words, but their face is not expressing it, or they're not putting it in the language that like makes me understand this is something going on behind their eyes, behind their the statements that they're making. And so observation is not just about what we see on the outside, but it also has something to do with how well can I understand a person's internal reality, even when I'm getting little information. So another more specific way of saying that is somebody says like, I'm really frustrated with my wife or my kids or whatever. And as counselors, part of what we know is anger can sometimes be another way of saying another thing, like I'm lonely, I'm scared, I'm sad, or something like that. And so a dude like myself, maybe not me, because I like to talk a lot, so maybe I'm not the best example, but somebody comes in and says like, I'm frustrated at my kids. And as a counselor, we're like, well, okay, frustration. We know that even depression can look like anger, and it can look really aggressive, oftentimes in men, but especially if they're presenting this way on the outside. My observation says they're fine and they're just mad and they need to cool off a little bit. But my assumption as a counselor is one possibility might be that they feel lonely and they're scared that their kids are not turning out the way they want, and they're fearful of them turning into something they don't believe is the right path, and so they're reacting in this mad way instead of saying, I'm scared and I'm concerned and I'm feeling like we have lost a little bit of connection, and if they continue down this path, we won't have that connection. And so we can kind of change the way that we direct our counseling work with them based on what we're observing, but we have to be able to read the internal and the interior, not just the exterior. So there's a whole bunch of that kind of conversation to have when it comes to understanding clinical work. And it gets more nuanced, because some of you are going to be like, no, I need to stick with the behavioral, what I can see, what I observe. It's facts. It's the only thing that I can really rely on. And some of you are going to say, no, I believe there is that kind of internal reality that I want to pay attention to. So I need to really sharpen and hone my observational abilities based on what I can what's the right word here? Project or assume based on my past clinical experience and on our research of what we know people experience behind the exterior. So hopefully that makes sense. It's a large topic. It's one of those things where we can say, oh, observation is simple. It's like talking about behaviors. And then it also can be looked at as a lifelong thing that can constantly be worked on, and you'll be maybe excellent, maybe great, but you'll never get it right all the time. You're always questioning and getting curious to sort of dial in, am I observing this right based on an assumption? Let me test it out. Let me talk to this person a little differently. some people get so good at this, and you'll look at them and be like, you've been doing counseling for 30 years, and it seems like you just sense when what's going on with a person, and you don't even have to talk to them that long. How did you know? And you're like, well, that kind of observation, a person walks in the door and they just sit down a different way, and you're like, oh, I see. I've seen this before. I observe in you the way you sit that you're experiencing this kind of emotion, and people get really good at that kind of observation, and that's one of those things that that separates the novice from the experienced counselor. So this is a thing that you can spend a whole bunch more time getting good at, or you can say, it's just a basic concept. I get it. It's fine. So anyway, in counseling, one of the things that we do a lot is a mini mental status exam, or another way of saying it is informal behavioral observations of client presentation. We're going to practice a bunch more with a mini mental status exam, but I'll give you just a snapshot of what it is. Pun intended, I guess. A mini mental status exam is kind of like a snapshot in time of what does the client present like in this brief moment? What is their affect in terms of like, do they look sad? Do they look happy? Are they energetic? Are they, I'm blanking on the word right now, what I'm thinking of, but not depressed, because I don't like to, I try not to use the term depressed outside of its clinical meaning, because it gets confusing. But maybe euthymic or something like that, which is just sort of like low energy and just blah, 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 just don't feel good kind of thing. So that's their affect. They could be in a status exam, you look at their hygiene. Are they well kept? Are they full of makeup? Is the makeup all off? Have they not showered in looks like a couple days, whatever? Like, so their hygiene is important. Do they know what year it is, what date it is? Are they part of the same reality that most of us live in most of the time? So there's all kinds of little considerations. We'll dig into the nuances, but really it's just to say, can I use words to explain what a person looks like at this day? It can become really important when one day a person comes in and they haven't showered, they're not clean, whatever, they look super depressed, and every test you give them says, yep, they have probably major depressive disorder, and they look pretty rough right now. They look pretty unwell. And then, 3 weeks later, they come back in and they're just a ball of energy and life is good and they're on cloud nine. You're like, you are as manic as I've ever seen a person. And so with those behavioral observations, if you keep doing those and you get in the practice of them, sometimes you can really put together themes and patterns based on a person's cyclical behavior or cyclical presentation. And that can help with things like diagnosing progress throughout counseling, or changes that help diagnose challenging things like personality disorders and bipolar 2 and 1 disorder, that kind of stuff. So those can become really important, and they're relatively simple but complex at the same time. We'll dig into those, and I'll give you more about what that means later. I'm going to skip over number 2 just for the sake of time. I've said enough about these. Hopefully you understand that it helps us make diagnostic decisions. It also helps clients become more aware by just saying, like, did you know that you always touch your face like this when you're sad or something like that? Or when you're playing poker, you're always like scratching your cheeks because when you're cheating, or I don't know what the thing is, but you guys know what I mean by that. The book describes formal methods, not so much the art. So we are talking about, when we talk about objective, subjective, a person's inner experience versus objective reality, we're talking kind of navigating this line between, are we talking science here that we can break down, we can quantify, we can categorize, or is this something that, are we talking more of like, after time and practice, I just feel something, or I have a gut intuition that leads me to this conclusion, and I assess for that, but I just rely on that intuition. Both of those things might be true. However, the only thing that I caution you is to put too much stock in one of them and say the other one doesn't matter, because we are building this muscle memory that comes after with practice and experience and all this kind of stuff, so that we can have an intuition, an ethical compass, an assessment intuition, and those kinds of things. So we just kind of have a sense, a sixth sense for this. But it also means that we can break down and categorize. Neither one of them is wrong. We just have to figure out how they fit. So that comes with time too. And then I'm just going to skip over the last one because I think I've kind of talked about that, given enough example of how observation is important for behavior and cognition and that kind of stuff. How much do I want to talk about rating scales? I think the only thing I'm going to say, because I've already talked about things being deceitfully simple a little bit, the only thing I'm going to say about rating scales is it's one thing to put down on a piece of paper, tell me on a score of 1 to 5, how are you feeling, whatever. But these things can be incredibly helpful. And I make this stuff up all the time. I'll say with clients of like, just like you go to the doctor's office and they're like, well, how bad is your pain? And they're like, 9. It's 9. I'm so much in pain. Maybe a 10. This is the worst pain I've ever felt. And you're like, you have a rash. So how does that work out? You know what I mean? Like, it just doesn't make sense. And sometimes those scales are hard to use. But the better you get at saying, well, on a scale of 0 being I don't feel anything, it's all basically numb, or I feel fine and normal, no problems, to a score of 10, like you probably are on the verge of passing out and dying, and this is the most excruciating, like existential pain you've ever felt in your entire life. Where are you at today? I always joke with my mom because she's got... There's lots of different ways to talk about pain, but when she goes to the doctor, they're like, "What's your pain?" She's like, "It's probably an 8 today," and she'll go back in a year later and like with like a really serious condition, and they're like, "Oh, how's your pain?" She's like, "Oh, it's probably a 7," and they're like, "Wait, what? How do we know?" You know? So there's lots of different ways to talk about these rating scales. And I like to make them up on the spot because it just can help me get a better sense of like what's going on with a person. On a scale of 1 to 1 being I'm really engaged and I think this is fun and there's nothing more that I'd rather be doing with my time right now, versus I'm having so much fun listening to this lecture, and 10 being I hate this and I'm about to shut it off and I think you're the dumbest person on the earth and I don't know why I signed up for this and I just hate listening to this. On a scale of how much fun do you have listening to this lecture right now, where are we at? And you guys can give me a number, and that gives me good information. So I make this stuff up on the fly all the time, and you can too. And it can give you so much more information. I've even, how much time we have? I've run into these situations before where I've used a really informal assessment. There was a guy I was testing who was in a car accident, and we were doing some employment evaluation kind of stuff. And I don't even remember what the question was, but I asked him this like informal rating scale question. And throughout the whole thing, it was like, oh, he feels terrible. He's got all these conditions, whatever. And I asked him this question of like, how big of a deal is this for you? Scale of 1 to 10. And he said a really low number. And I was like, oh, really? What does that mean? And so he started talking about this other thing. And he's like, we went in this kind of, 10-minute tangent down a rabbit hole. And the whole point of the story is that come to find out that like even though his diagnosis said this is serious, it's big, it's huge, it's a big portion of his life, we were able to talk through this. But I'm learning things and I'm growing, and it gave us a whole different understanding of the condition, which also changed the outcome of his legal case that he was in, not negatively or positively, but it just gave it a different direction. It told a different part of the story. And I don't know if I wouldn't have asked that question, would we have gotten to an understanding of what he's learning and how he's growing and how he's coping? Because it gave him the opportunity to explore, like, what are my resources? Who are my people? What's my perspective on my injuries? And what does this mean for the rest of my life? The case turned out really favorably because it it settled before it went to trial, but it gave both sides of the court case a different understanding of what his resources might be and what he needed. So it was really interesting. But anyway, enough said about that probably. We've already talked about collateral sources, so I'm going to skip over that just for the sake of time too. And this is our last slide. Now, something that I didn't say at the beginning, but I've said before, most of you have heard me before in class anyway. This is the last slide. We're talking about diversity. It's one chapter in the book. I haven't even asked you to read it. The reason for that is because it doesn't belong on one slide and we get over it. It's something that we should be bringing up over and over and over and over again, and it's relevant to every single chapter of every single part of this class. And hopefully that becomes clear. One of the things I want to give to you guys as sort of like a challenge or a responsibility is that there are things that I know from my white, middle class, middle aged, male, straight, whatever perspective. I'm like as white bread vanilla as you can possibly get. Hopefully I'm not ignorant and totally biased, which I am some, but I give you guys the opportunity to bring this stuff up in ways that I just can't understand. We all share different perspectives about these issues, and I'll try and talk about diversity. But if you ever think like, oh, there's a diversity thing to think about here, and there's a perspective that doesn't seem to be brought up, bring it up. Let's talk about it because we want to know. There's so many examples of how it changes the way we gather information and whether we're getting the right kind of information. So I'll talk a little bit about these things here, but I want to leave an invitation for you guys to say there's more here. And we have whole classes on diversity and multiculturalism, that kind of stuff. So this is just a big topic, and I really don't want to brush over it by saying, well, we did at the beginning of the semester. No, we cover it now briefly, but we should be bringing this up over and over again. Hopefully that makes a little bit of sense. This is not a political statement about like social justice and, like whatever, women's rights, black rights, kids' rights, whatever. It's not anything about that. It's about understanding life from the different perspectives of different people. And that's what we want to try and understand, because if we're not asking the right questions, we're not getting the right information, and we're not able to provide therapeutic benefit, at least in the way that I understand it. So that we could talk about that and break it apart, but we're not going to do that right now. Some of those things, let's talk about privilege. Let's talk about fairness. The terms edic and emic, what I mean by that is these are really like pedantic, stuffy academic terms, but they play an important role. So there are two groups that I've observed in my experience that this really applies to. One of them is the addiction community, and the other one is veterans. And there's more, but these are the big ones that I think of. If you haven't lived through addiction and walked through the 12-step process, there are lots of people who say, you can't possibly understand what I'm going through, and you will not understand what it's like to struggle. You won't understand what it's like to make choices or to have cravings this intense or something like that. And so if you're an outsider, that's what edic and emic means. Either you're an insider or you're an outsider. You've lived through addiction and you're an insider, you have that experience, or you've never had it. And there's this sense of like, you just don't get it, you can't learn, you won't belong. Same thing with veterans. If you haven't lived through the military lifestyle, because it's a different lifestyle, right? For those vets out there, you can confirm or deny if that's true or not. What this means is that for some of you saying like, well, I want to work with veterans, I think I can work with addicts, but I haven't been either of those things. What does that mean for me? Is there hope for me to be a counselor? My personal perspective is that regardless of whether you've been a veteran or an addict, there's possibility to learn and empathize and to help a person still, even though you may not identify as part of that community. One of the examples that I like to give is like, I'm not a woman. I don't know childbirth. I've never been through menopause. I've never had a period. I've never, I don't know, like there's a bunch of women's stuff that I don't get. You know what I mean? But does that mean that I can't learn about what a woman's experience is and try and understand it in a way that says, oh, I can't necessarily relate to that feeling or what it's like to do that, but I can certainly empathize with the struggle. And so therein lies how the interventions work and what how you can help, that kind of stuff. But that's a whole nother conversation. But the idea is that when people say, you can't possibly understand what it's like to live in an urban black community in the south side of Chicago. No, I can't. But does that mean that we can't, as two humans, have that connection? I think there's still a possibility. If there's not, then we should not be talking, and I'm not the person for you. And that's okay. Maybe you need to find a different kind of counselor, different help, or whatever. But if there's a chance that you can give me for us to be able to live in this world together and cohabitate in a way that makes sense, or that we can get along, or we can both support each other or live, create environments around each other to help us thrive, even if it looks so different, can we give it that opportunity or give it that chance? That's what we're talking about here with edic and emic, is outsider, insider, doesn't matter. And what does counseling mean if you're one of those two? So lots to unpack there, but we're not going to go into it for now. I guess the one thing I do want to say, though, is like when it comes to privilege, fairness, edic, all that kind of stuff, the way we assess somebody, we have to consider our own stuff, who we are and what our lens is for looking through the world. And part of a successful assessment is saying, these are parts that I don't understand. These are flaws that I have. This is part of my filter, and I need to ask information extra in order to get that. This might take me longer. It might be harder for me, but I can compensate by doing a proper and appropriate assessment of a person, but I can't assume as much, or I can't make as many assumptions about what I think to be true about certain kinds of people. It might just take more work. So I'll leave it there, and we can just revisit that more. Assimilation and acculturation. What do I want to say about that? I'll just kind of define the terms, and we can unpack it later if we want to. But assimilation is a group of people learning a culture and like assuming a culture identity of another group. Like, let's say I went over to, I don't know, Poland, and I wanted to live in Poland. I could assimilate to the culture by learning the currency, speaking the language, practicing some of the local cultural practices, that kind of stuff. They're very similar, assimilation and acculturation. One of the challenges, though, is that sometimes it can be forced and sometimes it can be voluntarily chosen. Like, I could choose to move to Poland and learn the language and participate in cultural practices, or, for sake of example, let's say I'm, a white, westward expanding, religious, previously European person, and I'm going into somebody else's space and then trying to make them change. Heard that story before? Here in Montana, that's a big one, right? So let's say I'm trying to force assimilate or acculturate these people who I don't think are getting it. And by the way, if you think, oh, I don't do that, or that doesn't happen, we do it all the time, all the time. We try and get people to understand our perspective. We try and tell them how we think living life should be. We tell them what's good for them and what, you should change this, do that, whatever. And if that's your perspective, that is somewhat arrogant, and it may not be the best thing for clinical practice. And I say may because I'm leaving a back door for myself for us to have conversation here. Many other people would say, if you're imposing your own value system on other people, you're doing it wrong. And there's conversation there. It's up for debate, so I'm not going to take sides right now, but that's one of those conversations I think is worth having. Looking at the time here, I got to speed through these. Labeling, categorizing, stereotyping. We'll have more conversations about this in discussion, so we'll get to that, and we'll, for the most people, I think people get it on a surface level, and we'll just add more nuance and more understanding to what those mean. Testing accommodations, I've briefly touched on that, and I want to talk about it more, but just for the sake of time, I'm not going to be able to. But I will say this. Accommodations are not meant to give people advantage, and that's one of the misconceptions about what accommodations are. If everybody else can hear an audible test or has the ability to read a test because they can like see the print on the page, like if I have a visual disability, and I want a person to be able to take this test because we're testing intelligence or aptitude or achievement or whatever, it's not giving somebody advantage just to read the question to them so they have access to that information. The point of accommodations is to get everybody on the same level playing field. That's the intention, that's the theory, that's what's supposed to happen, but that's not always how people understand that. So when we say like, I want to get this kind of information, but I can't get it unless I ask this question or come at it from this different angle or accommodate for this different group of people that simply don't respond this way. Accommodations are to level the playing field for the purposes of equity and fairness, not to provide advantage. There's a whole lot of unpacking there to be done, but that's where we're at. And then testing specific populations. There's too much to talk about here, but it could be age groups, it could be demographics, it could be by disability, it could be by diagnostic condition, it could be by cultural group. There's considerations that are unique to all of those things, and so the way we use test, depending on those different, all those different groups and different considerations, that changes the way things are used, and that has a lot to do with all of these things above: privilege, fairness, stereotyping, equity, all that kind of stuff. So a lot to unpack there, but we just can't do it today. And then more to come in the future. So that's pretty much it. Okay, so thank you guys for putting up with me talking for now. It's been an entire hour. But I hope this has provided something valuable to you in addition to what we've talked about in the past or from the textbook. And I will just either see you in class or see you in the next one. All right, bye-bye.